Hello everyone. Today we will discuss about a important practical topic, that is contrast-induced nephropathy. Contrast-induced nephropathy. So the thing is, first of all, where all we will use contrast in medical practice. So especially in CT scans, MRI and angiograms. When we think of images using contrast, we will be obviously worried about an entity called as contrast-induced nephropathy. But the thing is, its incidence is only about 2%. So this we have to remember. Incidence is very less. But suppose there are some risk factors in that particular individual. For example, if there is pre-existing kidney disease, or if the individual is taking any medication which are nephrotoxic medications, or if the individual is diabetic, or age is more than 75 years, or there are signs of dehydration already. So these are some risk factors in which incidence will increase from 2% to about 30% in these population. So these are the people who are at risk of developing contrast-induced nephropathy. And one more thing is patient with cardiovascular diseases, for example peripheral vascular disease or heart failure with reduced ejection fraction. Now we will deal what are the mechanisms which are leading to this nephropathy when we use contrast. So there are multiple things. For example, when we inject contrast, it will lead to vasoconstriction. So vasoconstriction will occur, which often leads to hypoxia and ischemia, leading to injury to the cells in the nephrons. Then that contrast sometimes might turn up as a toxic material to the cells, direct toxicity to the cells again. Or we can consider catheter-induced aeroembolism into the renal vasculature. So these are some mechanisms. And the thing is, if the patient is diabetic and suppose he or she is on metformin, again the risk of renal injury is high because this metformin might lead to lactic acidosis, which in turn will cause damage to the nephropathy, which in turn will lead to nephropathy. So ideally, if the individual is taking metformin, stop it at least 48 hours prior to the procedure. These are some mechanisms. Then coming to the practical identification of contrast-induced nephropathy. So how to identify? So whenever we consider contrast-induced nephropathy, few points we have to remember. Generally, there will be about 15% increase in the levels of creatinine after procedure. So this is a normal thing which we can see. So when to consider CIN is if there is more than 25% increase in creatinine from baseline, or direct increase of more than 0.5 gram per deciliter in creatinine. At this point, we can consider it as contrast-induced nephropathy, and here often this entity will be non-oliguric. That is, the individual will not have any oliguria in this case, and majority of the times it is a reversible condition within 2 to 4 weeks. So no need to worry in majority of the cases. And the thing is, this increase we can check after 48 to 72 hours of exposure. You might have seen many graphs related to contrast-induced nephropathy. So the creatinine will have a peak in 48 to 72 hours. So that's why we have to repeat creatinine after 48 to 72 hours. So this is the definition to consider as contrast-induced nephropathy. But there are other mechanisms when we are using contrast which are leading to nephropathy. So those are, one is dehydration can directly lead to renal injury irrespective of contrast usage, renal injury. Then comes interstitial nephritis. Interstitial nephritis after using contrast. So here we can see rashes, myalgia, eosinophilia as clue. Then comes cholesterol emboli. Cholesterol embolization can be seen. So the evidence is blue toes and there will be livido reticularis. Livido reticularis. These are some other direct mechanisms after usage of contrast which can lead to nephropathy other than the mechanisms we discussed in the beginning. Now, how to manage this contrast-induced nephropathy? So, the most important thing in management is about hydration. Hydration is very, very important. So, what we can do? Normal saline of about 1 ml per kg body weight per hour for 6 to 12 hours we can infuse prior to the procedure. So this is prior procedure. That is, suppose that individual is about 70 kg, so we can infuse about 70 ml per hour of normal saline for about 6 to 12 hours prior to procedure. Then after the procedure, same thing has to be done. Same process post procedure also. So this will give proper hydration to counteract the contrast. Second thing is we can use bicarbonate. Bicarbonate. What this will do is, see, contrast in some mechanism will lead to acidosis, which will acidify the tubular fluid and in turn lead to damage of the tubular cells. So to prevent that acidic fluid inside the tubules, we can give bicarbonate supplement. That is 3 ml per kg per hour of bicarbonate for about 1 hour prior procedure. Then after the procedure, we can give about 1 ml per kg per hour of bicarbonate for about 3 hours infusion. So these two things can be done. We can try with some other medications such as high intensity statins. High intensity statins prior procedure. This one can be utilized, and we can use injection vitamin C. Vitamin C of about 1 to 3 grams per day for some 2 to 3 days peri-procedure. That is, some 1 or 2 days prior and 1 or 2 days post procedure, we can utilize injection vitamin C also. So these are some management things when it comes to contrast-induced nephropathy. So the overall point is, incidence is very, very less unless the individual have some risk factors. And even if contrast-induced nephropathy occurs, it is reversible in 2 to 4 weeks. And the best thing to prevent contrast-induced nephropathy is hydration prior to the procedure and post procedure. Thank you.